This year's roundtable discussion will focus on global perspectives on AMR, and we have a very much a global panel today, and we'll be drawing inspiration from the six-part webinar series that the college ran earlier this summer. We will explore regional challenges and opportunities, highlight shared experiences and expertise, discuss the prevalence of AMR across different countries, and identify key priorities for addressing this urgent issue. I would just like to introduce the four panelists. You have all of their biographies, but I'll read out some of that. First of all, Dr. David Jenkins, who's a consultant in medical microbiology, qualified from King's College Hospital Medical School in 1985, and has been a consultant medical microbiology at University Hospitals of Leicester since 1997. He has served on several national bodies, including the councils of the RC-Path, the Healthcare Infection Society, and the Central Sterilising Club. He is the immediate past president of the British Society for Antimicrobial Chemotherapy, BSAC, and an elected member of the Executive Committee of the International Society of Antimicrobial Chemotherapy. As part of his BSAC presidency, he instigated and led the development of the Global Antimicrobial Stewardship Accreditation Scheme, which is a quality improvement initiative aimed at tackling AMR. His research interests include behavioural aspects of antibacterial prescribing. Welcome, David. Second, we have Professor Daniel Thirion, full clinical professor, pharmacist at Université de Montréal in Montreal in Canada, and McGill University Health Centre in Canada. Dr. Thirion is a clinical professor of pharmacy at the university since 2001, where his teaching responsibilities have been focused on infectious diseases pharmacotherapy. As a pharmacist, he founded and developed the Antimicrobial Stewardship Program in 2008 at the McGill University Health Centre. This program is now recognised as an exemplary practice according to Accreditation Canada. His research focuses on the impact of antimicrobial use on emerging diseases and development of resistance and appropriate use of antimicrobials in clinical practice. His main contributions to science have been the development of antimicrobial stewardship and optimal antibiotic prophylaxis in surgery. The numerous awards bear witness on the quality of work in all fields of activities. Third, very much welcome Professor Margaret Ip, Chairman and Clinical Professor, Faculty of Medicine, Chinese University of Hong Kong, in Hong Kong. Margaret Ip is a professor and chairperson at the Department of Microbiology at the Chinese University of Hong Kong. She is an honorary consultant microbiologist at the New Territories East Cluster of Hospitals of Hospital Authority of Hong Kong, and she has over 30 years of experience as a clinical microbiologist and as a fellow of the respective colleges of pathologists in Australasia, UK, and Hong Kong. Her research interests focus on drug-resistant pathogens, including MRSA, strep pneumoniae, Group B streptococcus, and other multi-drug resistant organisms. She has published over 300 international peer-reviewed papers and 5 book chapters. And last but not least, Professor Samuel Taiwo, Professor and Consultant Clinical Microbiologist at the Ladoke Akintola University of Technology in Ogbomoso, Nigeria. Samuel is a professor of microbiology and a consultant clinical microbiologist. He currently chairs the Hospital Clinical Microbiology Laboratory and IPC and AMS committees. He is a member of the National Antimicrobial Stewardship Working Group of the Clinical Microbiology and Infectious Diseases Society of Nigeria, Climidson, which produces the Climidson Manual for Antimicrobial Stewardship Programs in Nigerian healthcare facilities. He is the current editor-in-chief of the African Journal of Clinical and Experimental Microbiology and the Annals of Tropical Pathology. So welcome all of you to this panel discussion. I have a set of pre-prepared questions. Bear in mind, I'm not a microbiologist. I'm a chemical pathologist, so I will do my best, but correct me if I say anything that is incorrect. And I also welcome the audience to submit questions via Slido. So thank you. I'm going to start with a general question. What is being done well to address concerns about AMR in your region of the world? I'm going to start with Daniel.
Yes, good afternoon, everyone. It's a pleasure for me have the opportunity to participate in this group. So, if we're looking at what is being done in Canada, we actually have specific organizations within the government that are facilitating antimicrobial resistance monitoring. That's actually one of the most important things, that having access to the data. And we also have antimicrobial use measurements that are being nationalized. So allows us to track the events with antimicrobial resistance, and also enables us to be able to intervene with our antimicrobial stewardship programs. And also in Canada, what we have is something that we call an organizational process that is required in antimicrobial stewardship. So this is an accreditation process that requires all hospitals in Canada to have an antimicrobial stewardship program. This has increased manpower to allow us to be enabled to collect the data and have sufficient personnel to make the interventions in the field that will have an impact on patient care. So I've just summarized three aspects, and I would be glad to go into any more details if you have any more questions.
Okay, thank you. I'm going to move straight to Samuel, and the same question. What is being done well in your part of the world?
Thank you for the question. So in Nigeria, what is being done as far as AMR is concerned by the national government, the federal government, is that in 2017, we established or approved and developed the One Earth AMR National Action Plan 1.0, which ran from 2017 to 2022, and had five focal pillars in terms of education, awareness, surveillance of AMR, infection prevention and control, research and development, and antimicrobial stewardship. So this has been what the federal government have done. And since 2018, we have been reporting AMR bacterial surveillance data to GLASS. There's also the AMS implementation support that the Nigeria Center for Disease Control, which is the agency that oversees the AMR National Action Plan, has given support to some limited support to tertiary care facilities in the human sector. And just last month, the One Earth AMR National Action Plan 2.0, which is for 2024 to 2028, was launched, and we have focal areas that we are currently developing strategies to begin the implementation. We have largely received support from the Fleming Fund Phase 2, and we are currently developing these surveillance strategies that we have now expanded to include surveillance of multi-drug resistant organisms, fungi, genomic surveillance, as well as AMR burden estimate. So for now, these are things that the federal government is doing as far as AMR issue is concerned. I will be giving more other details as more question comes in. Thank you.
Thank you very much. And Margaret next. What's been done well in Hong Kong, or indeed further afield in Asia?
Well, I will just talk about Hong Kong this time, and I guess we started or improved the infection control, IPC, and AMR control within the hospital system. We have a public healthcare system based on hospitals, which look after about 90% of the population. So we also have a private sector that will not be under the public health, a bit like the NHS. So after SARS 1 to 4 to 5, we have a much bigger program on IPC, which included a lot of surveillance, SSI, surveillance, hygiene and infection control and hygiene educational program, AMR with antibiotic stewardship. So we set up the stewardship in hospitals for major acute hospitals from 2005 until now. So I was actually the chair of the work group in our hospital at that time. And with that, we also have we were monitoring big guns, the broader spectrum antibiotics, as well as aligning the antibiotic resistance pattern for the different hospitals from the lab point of view. So we have electronic capture of all the clinical management data, the pharmacy, the antibiotic usage, and the antibiotic resistance from the laboratory point of view. So we've been monitoring this, which to a certain extent, not quite real time, but close to, because they are accessible within department level, unit level, and hospital level. So if there is an issue with a certain unit or individual consultant, we are able to assess that quite quickly. So we have this work group running for the last 20 years or more than that now. And of course, with the WHO initiative of the strategic program on AMR, the Hong Kong government also set up a high-level steering committee in 2016. So that is aside from the sort of infection control practice and stewardship within the hospital systems. So this one is more extensive to cover the whole of Hong Kong. And below the sort of high-level steering committee, we also have an expert committee, which is composed of all the stakeholders. So we have the private care representative, we have the hospital authority representative, we have the microbiologists, ID physicians, public health people, the public health lab, the veterinary science, the agriculture and fishery, the food and health safety, and the environmental protection representative in the committee. And there are targets that have been set for what we should do outside the hospital, because in the hospital, we already improved the system within hospital antibiotic use since 2005. So we also found that a lot of the antibiotic consumption could be outside in the community, in the primary health care, but a larger also proportion from the animal side, from the veterinary, from the food farms, although there are few, not relatively much less. So we have been focusing on a broader aspect of antibiotic consumption within Hong Kong. And there have been a lot of different programs in monitoring the food safety, the AMR within food in reservoirs. They also set up an antibiotic stewardship for primary health care among the GP, which is mostly private. So there is much enhancement to cover a broader spectrum. In the second round of 5 years program, which started in 2023, we have much more targeted priorities. One of which is quite important, I think, is the mandate on the prescription prescription and dispensing of antibiotics by electronic means in the whole of Hong Kong. So even in pharmacy, from community and from primary care, there will be a much more precise capture of how antibiotics are being used. And this is one of the priorities among the targets.
Okay. Thank you, Margaret. Very comprehensive response. And finally, David, same question. What's been done well in the UK to address concerns about AMR, in your opinion?
Right. Well, first of all, hopefully you can hear me okay. I just have to apologize. I'm in Istanbul at the moment. I've been for the International Congress on Antimicrobial Chemotherapy, which just finished a few hours ago. So I'm actually in a hotel lobby, and hopefully it's not too noisy background, but
that's fine. Thank you.
So before I answer your question, just have a caveat that in the UK, of course, health is a devolved subject. So what happens in England isn't what happens necessarily in Scotland, Wales, and Northern Ireland. So my base is in England, so I can't really comment on the other 3 countries. However, just to say that it's almost 20 years to the day that John Reid put out targets for MRSA reduction. And that was probably one of the most important things to have been implemented, certainly in England, over the last 20 years to try and reduce antimicrobial resistance. And by and large, it was incredibly effective. And it still reverberates today in clinical practice. So I think that's something worth noting. In terms of the sharp end of AMR control in hospitals, it's around 3 things: antimicrobial stewardship, infection prevention, and microbiology laboratory capacity and practice. Of those three things, microbiology laboratory practice is by far and away, I think, the greatest success story. And that's down to a number of things, including, I must say, the Royal College of Pathology, because microbiology is one of the key disciplines in the RC path. And the RC path is one of the stakeholders for standards of microbiological investigations, which really interesting. In Turkey this week, I've had people come up to me asking about the SMIs and how to get hold of them. And of course, they're all freely available from the RC path website. And I would definitely encourage people to look at those, not just in the UK, but around the world, because I think they're really excellent guidance to carry out good microbiology practice. And as I say, that's really key to good AMS. Second, I think infection prevention practice is well established in the UK, at least in principle. In terms of practical implementation, I think it's still patchy and variable and some way to go. Thirdly, antimicrobial stewardship, I think we're still quite a long way to go in terms of good antimicrobial stewardship practice across hospitals, partly because we don't have enough antimicrobial pharmacists, and secondly, because it's not really yet fully embedded or whole enthusiastically embedded in clinical practice. And I think I'll stop at that point.
Yeah, thank you. I mean, I'll go on to my second question, which you sort of just started answering, and that is, what are the biggest challenges at the moment in the UK with regards to dealing with AMR?
Biggest challenges, I think the biggest challenge is clinical engagement still. I think there's still, surprisingly, a lack of appreciation of the threat that antimicrobial resistance poses, not just to the management of difficult to treat community or hospital-acquired infections with multi-drug resistant organisms, but also the greater potential to really impact on almost a complete range of healthcare implementation. A lot of healthcare in the UK utterly depends on effective antimicrobials. So, for example, virtually all surgery is protected with antimicrobial prophylaxis. Intensive care and hematology, oncology, transplant medicine all rely on effective antimicrobials to treat intercurrent infections. And without good quality, without antibiotics that work, we're really not going to be able to do a lot of the medicine that has developed over the last 100 years or so. So there really is an existential threat to clinical practice, not just in England, the UK, but around the world, if antimicrobial resistance develops in a position more than it is at the moment. In fact, you could argue it's already there. There was a really fascinating report from the European Centres for Disease Control some years ago now. They do these country reports, country visits and reports. The one from Italy was incredible. It basically said, unless things improve and improve quickly, you might as well give up on intensive care and hematology, oncology, and bone marrow transplant and various other high-risk clinical specialties. I think that's that's not just a vague prophecy. It's telling the truth.
Okay, thank you. Daniel, same question. What are the biggest challenges in Canada at the moment with AMR? You're on mute still, Daniel.
I'm sorry about that. So actually in Canada, we have a very specific situation that is proper to Canada, is access to antimicrobials, effective antimicrobials. Canada has a relatively small population compared to our neighbors in the US and compared to the European community. And this has posed a challenge to pharmaceutical companies that want to invest into Canada. They are exposed to an environment where there's a regulatory body for approval, and then there's 11 regulatory bodies that are in place to ensure appropriate use of antimicrobials. And so the companies are facing 12 regulatory bodies to have their drug approved. And currently we have only 2 of the about 15 new antimicrobials that have emerged in the market worldwide. And so we are currently challenged with the fact that we do not have access to appropriate antimicrobials, especially to treat multi-drug resistant carbapenemase producing organisms. And what this poses as a threat is that we have delayed access to antimicrobials that are commercialized either in Europe or in the US. And so we do have patients that are currently having complications, and some of them are unfortunately dying from the lack of access to these antimicrobials. So that's the first main threat to appropriate care to our patients. Other issues, I think, are similar to what we're observing across the world, is actually manpower, resources to be able to do all the work. We have shortages of pharmacists. We have shortages of nurses for IPC. We need appropriate trained personnel to be able to do the work. This is actually a challenge because our governments do not necessarily realize the level of training required to do the work in AMR. And so we are advocating to increase our education level requirements for practice in this field. Thirdly, I think that the other aspect is having access, again, and having appropriate antimicrobials used in clinical practice. So we're still seeing, despite a fairly broad range of antimicrobial stewardship interventions, we're still seeing between 50, 60, maybe up to 70% inappropriate use of antimicrobials. Our criteria are actually quite strict, and that's why we're having levels that high. It really depends on how you're doing your measurements, but we're measuring indication and diagnosis, which means that the diagnostic tools have to be in place, which are not always in place for our prescribers to have access to appropriate decision-making tools. That's one of the issues for appropriate use, and we see that about 30% of inappropriate use is an issue with diagnosis. And then the other 30% misuse is related to choice of antibiotics, dosing, duration, and that is a problem of training. And so again, we have to be able to integrate appropriate antimicrobial training in our undergraduate professional programs of our prescribers. And so I'll limit myself to those three issues.
Okay.
But I think that those are the ones that we are currently advocating for.
Okay, thank you. I'll maybe come back to teaching and training later on. Samuel, I guess there are many healthcare challenges in Nigeria, and AMR won't escape those. Do you want to tell us a bit about the biggest challenges you have?
Yeah, thank you very much. To talk about the challenges, I'm sure I'll take all your time. Well, let me look at it in these two ways. We have the challenge of AMR itself emerging and spreading because the major drivers of AMR are still very prevalent in Nigeria, overuse and misuse of agents both in the human sector and the animal sector. We have poor regulatory control over antimicrobial drug supply chain. So these antimicrobials are available to the populace over the counter, particularly antibiotics that are supposed to be on a reserve list and a watch list. These are available, and so people take this as they like. Of course, we also have the poor infection prevention and control, as well as the water, sanitation, and hygiene facilities, compliance and behavior of the populace. It's also a major issue to IPC and water, sanitation, and hygiene. Of course, a bigger problem is the inadequate clinical laboratory capacity, quality, including even timeliness of reporting, as well as utilization of microbiology laboratories is a big issue that we still have. And of course, there's continuous low awareness of AMR by the populace and the strategies, particularly at the community level, where the prescribing that is done is almost at that level. We don't have enough people to man those areas. And then, of course, we have challenges of implementing our AMR strategies. And basically, this is poor funding from our government to implement a lot of our AMR activities. So we rely majorly on implementing donors like the Fleming Fund. And we don't have, right now, we still don't have the government commitment to funding AMR activities. Of course, that leads to inadequate coverage when you are implementing strategies, particularly at the community level where the antimicrobial practice is really very bad. 80% of prescription in Nigeria is at the community level. Of course, also we have inadequate trained personnel, particularly also at community level and also in the private sector about antimicrobial stewardship implementation activities and monitoring, surveillance, and quite a number of things that we were still facing a lot of challenges. So these are very many, but I think these are just the two major headings that I can give these challenges that we have as far as AMR is concerned in Nigeria.
Okay.
Thank you.
Thank you. And finally, Margaret, your first answer implied that you have, um, you know, good mechanisms and services in place, but there must still be some challenges.
Yes, it's very challenging because we have an aging population with a really exponential rising elders and people retiring. So the hospitalization, as you can imagine, many of the chronic diseases and the infection rates are higher, much higher in the graph you saw this morning earlier. So we are, I mean, in the normal circumstance in the public hospital, we are like 110% bed occupancy during the flu season. Now we are 110% bed occupancy well before any flu season. So most of the time we are very, very busy. And with that, of course, and staff shortage, we're also short of nurses and medical personnel, as well as other healthcare personnel. So IPC is very, very hard, even though we do have some manpower, but it's short and we are very crowded. So that's a real challenge. We try to minimize spread and outbreaks or cluster. So there's a lot of screening, a lot of testing, like CPE screening used to be like a handful in 1 case, 2 case in the hospital per day. Now it's in terms of hundreds of cases, like the number just doubling, tripling over the last few years. And I mean, in the community or screening carriers, is becoming more endemic to a certain extent. It's really exploded, in terms of before you can handle the single carrier and screening within the ward or the cohorting and then screening the surrounding cubicle, for example. Now it's like multiple cubicles and multiple wards, and it's really a real challenge. So we are still trying to prevent spread and identify the case early. Luckily, we still don't have a lot of infection, but we are starting to see CPE infections. They used to be just carriers, so they don't come in with an infection, and they don't hopefully get infection during their stay. But we are seeing a difference. I mean, the numbers are going up. So those are areas that we need to improve on and how to accommodate. We cannot accommodate. We really have to change the practice so that it works.
Okay,
because
thank you.
So these are staff challenges, increased aging, hospitalization challenges within the population structure. So the IPC practice is challenging. Stewardship, of course, it depends on the baseline. If we start with resistance, our empiric choice of antibiotics are quite small numbers anyway to start with. But diagnostics is not too bad. We do a lot of multiplex PCR. We have a turnaround very quickly, same day or same morning results to get rid of a lot of antibiotic usage from that point of view. But there are still many gaps that we can improve on.
Okay, thank you. I guess AMR strategies in most countries are very much dependent on keeping the attention and the funding from our governments. How do we keep interest of AMR issues, really at the top of the page for government? Most of us wake up this morning to find out that Donald Trump has been elected as the new president of the USA, and we know, in his last administration he withdrew from the WHO and hasn't been a friend of this kind of work, and we also hear that Robert F. Kennedy Jr., a noted anti-vaxxer and conspiracy theorist, is likely to be put in charge of health agencies. Or at least be the main person in the Trump cabinet to take forward that. So it's quite worrying from that perspective that we are seeing, various government responses that are variable. How do you manage the relationship with government in your countries? I'm going to start with Margaret on this one.
Well, we experienced many different outbreaks and pandemics. The H5N1 back in 1997 7 or 6, we have to slaughter 10,000 chicken in one day before New Year's Eve or something. So we are on the lookout for new emerging virus or infection. So medical healthcare people, that we have pandemic plans and outbreak plans. It's very challenging because when people are stressed out, it makes it very difficult. But at least there is priority from the top down, from the hospital level, administration level. Funding, they do put a lot of priority on risk management in hospital because of the experiences we had, because it really jeopardized our economy in the first SARS. And of course, during COVID, I think many countries learned, and felt the economical loss. So we have that as a high priority that we try to contain as far as we can. But of course, when the problem gets worse, we also have to keep changing and keep modifying and upgrade or implement new methodology. So we move along, but it's hard. It's not something you think you handle it and you keep it static. It's not something like this. We keep meeting emerging viruses, emerging infections, and keeps, it keeps coming. And Hong Kong really experienced so many of these. H5, H7, of course, everyone saw the H1N1, which was okay. And then, of course, the COVID and many others. And we have borders that are quite accessible to a certain extent. So we do have incoming, various infection that we have to be on alert at the borders.
Okay, thank you. I'll move to Daniel next. Is the Canadian government aware and supportive of AMR issues?
So you're talking about the political environment, and actually, I just want to bring the attention on the fact that the population trust in science is actually changing, and I think that's what you're trying to underline, is that we have issues with maintaining the trust in science, and I think that's where we want to focus on how we're doing it. Actually, our political environment currently is scientific. They base their decisions on evidence. They make their decisions logically, and so we do see the threat that is arriving from the environment. Our leaders are mentioning this threat is existing, and to respond to this kind of threat, there are different types of solutions that we are putting forward. The first one is maintaining our activities of outreach in the public sector, and I think this is one of the ones that we are focusing on currently. For example, we're having the Antibiotic Awareness Day that is worldwide, which we are engaging in to maintain exposure to the importance of the antimicrobial issues. The other one that is actually innovative in my perspective is that our leaders are focusing on passionate ways of looking at our science. And I think this is engaging the public in our passion is one of the aspects that is innovative that we have not been very good at, because it seems that some part of the population is mostly emotional. They are having emotional reactions to the environment. When they're seeing threats, they will emotionally react, which does not necessarily lead to the appropriate actions that the people are what we're expecting to have. The pandemic, we're seeing people react and saying that it's a conspiracy. It's an emotional reaction that they're having. And so this is why we have to engage them through different aspects than what we're used to doing with our science. And so it's not necessarily specific to AMR, but we are looking across the board with our leaders on how to respond to these issues within our science populations.
Sure. It's hugely challenging. David.
Right. Well, there are a number of things. I think education is key. Education of the population, of the general population, of the public, education of healthcare professionals, and educating political leaders, organize, and hold to account. I think are the headlines in all of this. In terms of education, we've heard Daniel talking about emotional. I think emotional can be a very strong way of educating people, particularly when you get either people who've suffered personally or who their friends or family have died from multi-drug resistant infections. It really helps drive a kind of body of opinion. And I mentioned about John Reed 20 years ago. Well, some of those people who've been in this business a long time will remember that the reason why John Reed issued this declaration of reducing MRSA by 50% was because of a newspaper campaign. And this was a campaign which itself was prompted by the bad outcomes that people have had from MRSA infections. So, individuals acting individually, but also together, organizing, can really make a big difference if they push at the right places. In terms of professional organizations such as BSAC and the RCPath, so the British Society of Antimicrobial Chemotherapy, and Royal and other, and there are quite a few in organizations in the UK linked to antimicrobial resistance, working either individually or together, and even better together, organizing and pushing politicians. The BSAC provides a secretariat for the all-party parliamentary group on antimicrobial resistance. And this is a really great way of getting in touch with backbencher parliamentarians and feeding into them issues that they might want to raise either in the House of Commons or the House of Lords. And one of the things about parliamentarians is that when they ask a question, it has to be answered by the government, either as an oral reply or written reply. So it's a good way really of holding to account. And I think that's the last aspect of this is we need to say we recognise government as you're responsible for our safety. You publish things like the National Action Plan, and you make in the current one 30 commitments, but are you going to deliver on them? We know that governments have limited bandwidth. We saw that during COVID because Brexit really took over, and as a result, the government really wasn't well prepared for COVID or anything else for that matter. So we know that governments can only handle a certain amount of tasks at any one time. We have really got to make sure that the tasks that we think are important are tackled, bearing in mind that government, and in particular civil servants, actually really quite small, at least in the UK. And they're subject to churn as well. Civil servants come and go. So unless you keep the pressure up on them, it's the easiest thing for them to do is to forget about it and do nothing. It really is important to organize and hold to account. And the other thing then is it just governments? And I don't think it is. I think there are various political spheres. And this can be at a local level, a regional level, city level even, as well as national and international levels. So many people will know that the United Nations General Assembly meeting in September spent a whole day just on antimicrobial resistance. All the governments around the world signed up to a political statement, 16, 17-page political statement on AMR. All of us now have the opportunity to hold our individual countries and governments to account. But going back to kind of a more local level, one of the most incredible phenomena that's happened over the last 100 years is urbanization of the human population. There are many more people live now in cities than out in rural areas. And cities are really the kind of really well designed for spreading resistance. So it may be that if we speak to local governments and highlight the problems of resistance in our local settings, in our cities and towns, and lots of these local governments have healthcare responsibilities, public health responsibilities. Getting them to do things may be much more productive than trying to get governments to do things. So I think you really have to act politically here. You have to understand where all the levers and buttons are, and make sure you organise sufficiently well to get action. I'll stop at that point.
Okay, thank you, Samuel. David touched on aspects of education. Educating not just government, but doctors, nurses, other healthcare professionals. How challenging is that in your country? And does collaboration internationally help with that, now that we can do a lot of online teaching, for example?
Yeah, thank you very much. Education is is an area that is very strong. I think we are doing that at particularly at the tertiary care facility level. And what we need to do is actually to go down beyond tertiary care facility down to the secondary care level and of course to the primary care level, where that education is actually highly needed because you have a lot of people that are ignorant, they are not aware of antimicrobial resistance or antimicrobial stewardship. And so this is an area that I think we are working on. At the society level, the professional association level, my association, the Clinical Microbiology and Infectious Disease Society of Nigeria, has been in the forefront of antimicrobial stewardship implementation, training, education of our members and other stakeholders within the tertiary care facility. In fact, we developed the medicine manual, which was supposed to guide antimicrobial stewardship implementation in all the 3 levels of care delivery in Nigeria. And we've been trying as much as possible to train people, mentor some facilities using these guidelines so that they can, start their program, implement the activities, and also sustain and maintain it. So we're doing that. Also, we're getting to the chief executive of care facilities. We're engaging them in terms of, so that they can have a buy-in into programs, establishing this thing and supporting the program in these care facilities. So we're doing that. We're also engaging there is the National Primary Healthcare Development Agencies that is responsible for the community level. And so we're engaging the Director General of this agency to be able to, educate people at the community level, because it's a big challenge. Community level is actually a very, very big challenge in getting down there. But these are, programs in the pipeline to extend antimicrobial stewardship program, education and awareness down to the community level. We'll be leveraging on the World Antimicrobial Resistant Awareness Week, but we know that's just once in a year. It has to be continuous thing that we are doing. So these are areas that we are looking at in the National Action Plan 2.0, such that we can bring AMS education, AMR education down to the community level, where antimicrobial use is actually greatest in our own community. Thank you.
Thank you. In terms of collaborative educational ventures, we're seeing some fantastic, offerings coming from North America. I could also plug the pathology portal that's been developed through RC Path, and there are many others. What did the rest of the panel think about, the importance of education and being able to collaborate, especially with, online and virtual things, like some webinars, like some conferences and various other things?
Well, let me follow up with my discussion on education. This is a very good forum for us to discuss that. We have had a memorandum of understanding with the Royal College of Pathology, that's the National Postgraduate Medical College of Nigeria, and the Royal College of Pathology. And we've had at least 2 virtual workshop training on antimicrobial resistant global perspective and antimicrobial stewardship, one in 2022 and one in 2024. And we want to build on this because this is a very good collaborative effort. The workshop we had in 2022 was so helpful that it assisted us in developing the guideline that clinicians developed in 2023. So we think there is room for this continuous collaboration between the Royal College of Pathologists and the National Postgraduate Medical College, as well as Clinical Microbiology and Infectious Disease Society. But beyond that, I think there's also room for us to have, maybe joint applications, for example, maybe applying for grants that will assist us in, in training our people here, or in some innovative researches that I think Royal College of Pathologists with the National Postgraduate Medical College could, assist this way to be able to get, some of these grant and funding that will assist us in some innovative AMR researches that can assist in AMR intervention in the developing countries like Nigeria.
Okay.
Thank you.
Thank you for acknowledging that collaborative effort. Any other comments on education from the other panelists? David?
So, yeah, the British Society of Antimicrobial Chemotherapy has education at its heart, recognizing that different countries will have different problems and different abilities to respond to their challenges. As part of our educational program, we have collated a range of different educational packages, some that BSAC have made it ourselves, others that other organizations have contributed. And we've collected them together on something called the Global Antimicrobial Stewardship Partnership Hub. And these are open access, so anybody can get hold of them, can go in and search through them. There's a search function which allows you to pick and choose the functions that are best for you. So you can get those through the BSAC website, which is www.bsac.org.uk, so bsac.org.uk, and then you follow the links through. As I said, these are completely free and open source information. We've provided massive open online courses on antimicrobial stewardship, courses on microbiology laboratory practice, and then there are other organizations such as UCAST, so the European Union Committee for Antimicrobial Sensitivity Testing, which I think in a really very valuable program have set up standards for testing bacteria for antimicrobial susceptibility. And what is very key here is that this package of work again is completely open for anybody to access, unlike, for example, the American CLSI package, which is very expensive to get hold of. And not only do they provide you with the written material, there's also videos on YouTube that you can watch and been translated into many different languages. So it really does make it a lot easier than it has been in the past for all laboratories to work well. Of course, the challenge is that many countries around the world do not have laboratories, certainly not enough laboratories, or even any laboratories in some places. And I think that's where other organizations such as Médecins Sans Frontières have a potential role. They've developed a facility known as the Mini Lab. Now, it's in very, very early days at the moment. It's only being used in a couple of locations around the world. But it's a tremendous development. They put an awful lot of thought into it and created effectively a laboratory. It's a transportable laboratory. It's one you move to a place and then set it up and keep it there. You don't move it around. But they've developed this facility, which is both the laboratory infrastructure itself, but also the training to use it. And after about 3 months of training, people with no expertise in microbiology, no prior expertise in microbiology, can be producing extremely good, high-quality results. And of course, it creates a problem because you suddenly realize what sort of resistance issues you have. But I think that's a good problem because it's a starting point. I think the organizations like MSF with the Mini Lab really do need to be applauded for the work they've done.
Okay. Okay, thank you. I'm going to slightly move subject because I've got a few questions I want to try and squeeze in that are specific to some of you. Daniel, how important is the evidence and the science around preoperative antibiotic prophylaxis, which I think you've done some work in?
So when we were starting our antibiotic stewardship initiatives, we had some data to guide us in the interventions that we want to prioritize. So if you look at antimicrobial prophylaxis in our healthcare institutions, it accounts for about a third of the amount of antimicrobial use. On the other perspective, if you look at the amount of nosocomial infections that are occurring in your hospital, it really depends how much surgery is going on. But it accounts also for a vast majority of infections that are in the nosocomial arena. And so this is why we focus on antimicrobial stewardship in antibiotic prophylaxis. And actually, the guidelines are very well developed there's a fair amount of evidence. If you look at the impact of antimicrobials in surgery, the evidence goes back to almost 100 years ago when they're initiating antiseptic measures or antimicrobial prophylaxis. And so we've noticed when we implemented our own interventions with our surgical teams that we managed to improve antibiotic use in that arena, and it decreased the incidence of infections by about 50% across the board. And what I mean across the board is that we decreased the neurosurgical interventions by 50% from 1%, which was extremely low, to 0.5%. But we saw this in our surgical solid organ transplant arena. We saw this in cardiac surgery. We saw this in our general surgery. So antimicrobial use can be improved, and it has a direct impact on the incidence of nosocomial infections, and therefore a direct impact on overall antimicrobial use. And of note, I just want to make this clear, but appropriate antimicrobial stewardship in antibiotic surgery itself has its impact independent of your infection control practices. Infection control practices are actually extremely important in surgery. They will have a huge impact on infection control, but the proper use of antibiotics in that arena has its own impact, and you can operate or you can intervene on those the optimal use of those antibiotics to improve outcomes. And what is fascinating is that surgeons actually don't have that much training on appropriate use of antibiotics. And so they greatly welcome our interventions because post-op infections is the cause of mortality in 50% of their cases. And so this is one of their major interests, that they really applaud any help that they can achieve and help to be able to improve antibiotic use in their arena. And so I just want to focus on some of the interventions that were key. First is to have the buy-in by the surgical team, surgical department heads. If you can demonstrate that you have the data and that your interventions have an impact, they will bring the whole team on board. Second, we need collaboration among the surgical team. So what we noticed in our interventions is that anesthesiologists and surgeons were not taking any of the responsibility for antibiotic prophylaxis. And why is not because they were unwilling to do so, but because it was not clear. And so the responsibility was just getting shifted around all over the place, from the nurses to the anesthesiologists to the surgeons. And so getting an appropriate line of responsibility is actually quite important. And then, of course, all the help that you can get from the nurses in the surgical theater is actually quite important for documenting and appropriate administration of the antibiotics.
Okay, thank you for that, Daniel. I'm going to move to Margaret next. You know, the concept of the emergence of drug-resistant pathogens and multi-drug resistant organisms is something that you've done a lot of research in, and is the evidence pointing towards things getting considerably worse regarding the emergence of those pathogens?
I mean, from a hospital point of view or from Hong Kong point of view, and globally, I think gram-negative is probably the key issue, which are the critical organisms. Gram-positive, probably I will not talk about at this moment. For gram-negative, I guess the CPE, the carbapenem resistance, and of course the ESBL. For CPE, we have noticed we started the screening program in hospital from 2011 when the CDC put the guideline, and most of the infections were brought in, like from hospitalization abroad, etc. And of course, the numbers went up. I mean, trickling in from all our neighboring countries and various visits outside and brought in. But to a certain period, suddenly we just start accumulating numbers, and we now looked harder and we found there is reservoir. And there's a food chain as well. So we can find CPE from pork, from wet markets and various places. So the challenge is how to contain this. And I think there's probably low carriage in many of us. So it's becoming probably endemic in very low density in our stool, I mean, from various sources. So I think it's going to be a big challenge. In hospital, we are still continuing the screening program and cohorting all this, and this is a real challenge. Totally, I mean, it's just out of completely overwhelmed. So I think something has to be done on this, definitely. And ESBL, of course, is probably endemic and in many places depends on the percentage coverage in the population.
Sure.
But the number of infections don't seem to have gone up significantly, but of course they will contribute to the community UTIs and various infections over time. So yes, we are seeing a gradual increase despite in trying to improve the antibiotic use, improving the IPC, increasing educational activities, but because of the way the population structure, the urbanization, well, we are crowded anyway, and the source and the reservoirs that we are able to identify and may not be able to eradicate. So these are some new challenges we have to face. And of course, a new mechanism of resistance. We get all sorts of CPG that we have to be able to type and sequence and PCR very quickly to give the appropriate antibiotics if they are treatable. So yes, a lot of challenges in the lab as well.
Okay, thank you for that. A question from the audience I'm going to direct to David. It's about the UK. The audience member has commented that sepsis has become a bit of a sort of buzzword and drive in the UK, with the view that it's being missed a lot of the time. Is this drive to try and investigate and detect sepsis leading to potentially overprescribing of antibiotics, and how does that influence AMR?
Okay, I mean, first of all, I certainly don't want to detract from the message that the sepsis community are pushing, which is that patients can die very, very quickly from overwhelming infections. And that's clearly true. And part of the management of sepsis, of very severe overwhelming infection, is antibiotic treatment. And when you don't know the nature of the organism that's causing the infection, then unless the only way of tackling that rationally then is to use broad spectrum antibiotics. Clearly, if you know what the organism is for some reason, or if you've got a very good grounds for suspecting what it is, then you can be more restricted in the antibiotics you give. But I think it's entirely reasonable to use broad spectrum antibiotics for the immediate management of overwhelming infection. However, the caveats then, first of all, you must collect specimens before starting antibiotics. It doesn't take more than a couple of minutes to take a blood culture or other appropriate specimens before giving the first dose of antibiotic. Without those specimens, you'll never know what the cause is. And that not only doesn't do antimicrobial stewardship any good, it actually doesn't do that individual patient any good either. Because if we don't know what's causing the infection, we can't give narrower spectrum antibiotics to that patient, or just the antibiotic to make, because sometimes the antibiotics you give, even those aren't effective. So it's really, really important for the individual patient management as well as general antimicrobial stewardship to take appropriate cultures quickly. So that's the first thing. The other thing is that whilst the sepsis, the community pushing improving knowledge about sepsis know what they're talking about, unfortunately, there's been a kind of loss of value of the term sepsis. And now people will use the term sepsis for anybody who's got a bit of a temperature, and then start giving them meropenem, or even patients who don't even have an infection, but have things like increased rate of breathing, for example. And of course, you could have, and I've seen this myself, I've seen patients with increased rate of breathing because of the pain of a myocardial infarct being given antibiotics, meropenem for the myocardial infarct, which of course is complete nonsense. And so that's an example of a loose use of language, which I think is really important to tackle. Secondly, around sepsis, is the latest thinking is that it's probably not so critically important to give antibiotics within minutes, but certainly within hours. But try and get some investigations done, first of all, to more readily localize the source and the nature of the infection. So I think that's really important to know as well. So these things what seems to be a simple message actually is much more nuanced when you look at it a bit more. And when it comes to stewardship, the other thing about stewardship, that again, a common misunderstanding about stewardship, people think it's all about reducing antibiotic use. That's not the answer. Stewardship is about appropriate antibiotic use. So when people don't need antibiotics, for example, when they've got a viral infection, they shouldn't be getting any antibiotics. When they've got overwhelming sepsis and you don't know what's causing it, then broad spectrum antibiotics are entirely reasonable. And that is all good stewardship. So I think we should be, get that. It's complicating the message a bit, but I think it's worth the effort to try and explain that.
Sure. Okay, thank you. And we're almost out of time, but I'd like to bring Samuel back in. Samuel, you made a point in our chat, which the audience can't see, is that that in Nigeria there are issues with traditional medicine sellers and combining various herbs and so on with antibiotics, and that's a big challenge. The question I was going to ask you though is about Clamidson and the work you do there. I mean, obviously you will be very limited because you're such a small society with minimal resources. How do you manage to sort of penetrate to have an effect in that situation?
Yeah, thank you. Yes, the Clamidson is a very small association, but has been very effective and at the forefront of the antimicrobial stewardship implementation in Nigeria since 2015. When the first global point prevalence survey was conducted, in which 2 of our facilities participated. So since that, we have provided training and link for Clamidson supported facility to conduct global point prevalence survey of antimicrobial use and resistance in such a way that it could generate data so that they can have their facility management attention and then support the establishment of AMS. So this is what we've been doing as a very small group. We have also adapted the CDC guideline for use so that we can use that to assess the core elements of AMS and perform a SWOT analysis. We've been able to do that for many facilities. We have also been leading, in awareness campaign during the annual World AMR Awareness Week. And in 2020, the Clamidson organized an international conference that was solely on antimicrobial stewardship. So these are things that we have been doing as a very small group. In 2018 or thereabout, we established a particular working group within that society, and they produced, after about 5 years, they produced the Clamidson manual that I talked about, which was launched in 2023. So these have been what we were doing. But just recently, the Nigeria Center for Disease Control, which is the agency that is in charge of AMR, implementing AMR strategies, recognized what we have done so far and invited us. And now we are the one, our members are now developing a lot of strategies for the National Action Plan 2.0 that have just been approved. So we're developing so many things for them, in terms of surveillance, laboratory capacity building, implementation strategies, both at the tertiary and secondary, as well as primary care facility level. We're also developing protocols for AMR burden estimation because we don't have, what we have relied on are those that are done by extrapolation, but we want to be able to also determine what the burden is around here, which can assist us in developing good policy. So far, we are a very small group, but rather than for us to fold our arms when our government is not doing anything, we started doing some things that we could do. Now the government has recognized us, and we are now working in partnership with the government. So we are looking at moving forward in implementing the National Action Plan 2.0. We think that our effort has not been in vain, and we think that we are going to work in partnership with government to be able to move the AMR strategies forward from where we are right now. Thank you.
Okay. Thank you, Samuel. Hugely challenging, but we must applaud your efforts. I now have to bring, sadly, this session to a close. We've reached our time. I'd like to thank Samuel, Margaret, Daniel, and David for their time today and for their contributions. It's been much valued, I'm sure, by the audience. And as a chemical pathologist, I've learned a lot today about AMR that I'm sure I can use in my own clinical practice. So thank you, all 4 of you. Good morning, good afternoon, good evening, whichever it is for you. It's been great speaking to you all, and thank you for joining us. Goodbye. Thank you.